Hello, hello, Alan.
Hello, hello. Nice to meet
It-
you in person, sort of.
I know it's a pleasure to meet you in front of all of our friends.
Right? How was your flight?
You know what? It was great.
Good, good,
It
good.
is 11 a.m. here in New Zealand.
Well, good morning.
Thanks.
Yeah, isn't this awesome technology?
I
Uh,
love it so
we
much.
can we can talk across the world. Okay, we're going to be hearing now from Dr. Alexander. Dr. Alexander is going to be speaking on auditory processing, and I'm really looking forward to her talk. I think a lot of people are. Let me just give you a little bit of her background. She got her bachelor's degree at the University of Kansas, uh, and then her master's at the University of Kansas, and then her doctorate at the University of Kansas. So, but you're not in Kansas anymore.
No, I am not.
That's a line.
You
Um,
know, it's more expensive to get there than clicking heels, if I'm honest.
I know, and you don't have the ruby slippers anyway. So, Um, she is a member, of course, of American Speech, Language, and Hearing Association, and the New Zealand Audiological Society. Um, she is currently the director of education for the Auditory Processing Institute and was the clinical director of Central Auditory Processing Network. And she had the good fortune for a number of years. I don't know, how long were you with Dr. Katz?
21. Well, we were connected for 21 years until he passed away in July.
21 years?
21 years. So 2004.
Wow.
I know.
So
It's
you were
amazing.
right out of the womb then, weren't you?
Right? Straight out.
12. Geez, that's incredible. Who
Yeah.
recently passed away, July.
Yeah.
Most of you are probably, or a lot of you are probably familiar with his work in auditory processing. He was really kind of the bellwether for that. Did a lot of wonderful, wrote a lot of wonderful papers and did a lot of great work. Probably laid the groundwork for much of what you do now.
100%. Yeah.
Um, I just real quickly, she's got lots of presentations and awards and things, but real quickly, you put together a TED Talk, which I found absolutely riveting. And
Thank you.
if you people have a chance, I highly recommend you. It's on YouTube, and it's just a really riveting talk. I enjoyed it very much. In any case, so we're going to turn it over to you for the next while, and I'll come back. If you folks have questions, please just wait until the end of her talk, and I'm sure she'll be happy to answer any questions. Take it away.
Fantastic. Thank you so much. Okay. How many people see a QR code on their screen? If you are not used to doing Kahoots, you can take your phone, open up the camera app, click the QR code, and jump into a survey that we're just going to go into. We have 130 of you in the audience right now, and I really want to know what's driving you, what you're excited to hear about, because it'll help me focus my talk today. And I'm really excited about giving this talk to you. So jump in. I do see that some people are coming in and going out. I'm probably going to wait until I see about 40 names on the screen, and we're at 29 so far. This is going to help me know how to focus my talk. Maybe I might skip over a few parts as we're going. But I'm really excited to talk to you about auditory processing. Alan, thank you so much for the opportunity to get to chat. This is going to be a really fun activity. I also have heard that the chat box is open for discussion as we are going along. If you want to throw questions or ideas or insights in there, feel free. You don't have to wait to the end. I will answer questions as I'm going if I feel like I can slide it right in there. Okay, fantastic. We've got some good people in here. If you're not able to get in, do not worry. You can answer in the chat box and your friends will respond to you there, I guess. All right, here we go. Let's start with a Kahoot. Please feel free to interrupt me if my sound ever isn't awesome or if you can't see something on my screen. So first of all, let me find out who I'm talking to. Who is in here? And if you click other, can you please put what you are? Are you a dangerous interloper? I need to know. You know, lots of people trying to hack to get into these talks, right? Okay, let's find out. So a majority of you are audiologists, 78%. Wow. 20% are hearing aid dispensers, 2% ENT. That is fantastic. That's really helpful for me to know. All right. I want to know where you're joining us from today. Where in the world are you? Is this going to work on your phones? I don't know. Haven't quite tried it like this before. Let's see where you are. I know that House is in LA. I used to live in Ontario, California. I think some people consider that the armpit of Southern California. Uh, what a beautiful way to, oh, Betty is also in California. Fantastic. Okay. Look at this, my friends. Either this isn't working very well, or we actually have some people joining us from Africa and India, and quite a lot from California. Wonderful. Okay. What audiology services do you currently offer in your clinic? Now, if you're not in an audiology clinic, maybe this doesn't apply to you, but I just want to know what you do in your clinic. Select as many of these as apply. Fantastic. So a majority are doing hearing aid dispensing. That doesn't surprise me too much. A third of you are doing cochlear implants. What? Guess what? I'm going to be talking about implantable devices and auditory processing in just a little bit. So I'm very excited about that. Tinnitus and misophonia, dizziness and balance. Wow, a quarter of you doing that. That blows my mind. 22% with auditory processing testing, 9% for auditory processing treatment. My mind is blown. I am so excited about this. I would not have guessed. What is your current comfort level with the concept of APD? I'm really glad I didn't just guess about y'all, because I am seeing a very different perspective here. So really wonderful. Okay. A majority of people here feel either a little comfortable or not at all comfortable. Wow, that's really interesting. Okay. When was the last time you administered an APD evaluation? Someone could be administering one right now as we speak, huh? Just kidding. Thank you, Betty. I see your response that you feel fairly comfortable with it. Good. Good. All right, let's see. Okay, so 44% say you've never done an APD evaluation, and 29% say never/grad school. Am I right? Fantastic. And if you said other, pop in the chat box what you mean with other. Next, when was the last time you administered in-person APD therapy? The person is in your clinic or online with you doing auditory processing therapy. I'm still shook that so many of you do CIs. I can't wait. You might find this talk incredibly relevant. Here's hoping. All right, never. Wow, lots of nevers. Okay. Oh, who's competitive? What's the youngest age we can assess for auditory processing difficulties with normative data? This may surprise you, especially if you graduated more than 10 years ago. The correct answer is 3.5 to 4 years. So we have the ability to assess children down to the age 3.5 to 4 with normative data, that is probably, we will get better than that as time goes on, but a majority is 3.5 to 4. The misnomer in our profession is 7 or 8 years of age, because tonal processing, it has a lot of variability before the age of 7. But unfortunately, a lot of people thought that applied to all auditory processing tasks, and that's tonal processing. So I think it's great to update our information. Ooh, let's see. Is anybody, me is winning. That sounded like really good grammar, right? Go me. All right, true or false? We can assess the auditory processing abilities in a person with hearing loss. Based on my previous comments, you may not be surprised to hear that it is possible to assess the auditory processing abilities in a person with hearing loss, and it is what I will discuss that a bit today as well. Okay, what was your first thought? 1 or 2 words when I say APD clinical work, and you can be honest. This is anonymous, so you can say whatever's on your mind. Spill the tea, y'all. Okay, let's see what everyone said. I can't wait. Okay, we've got not for me, diagnostic, interesting, tough, dichotic digits, interesting, yay! Not familiar, auditory processing, time consuming, boring, counseling, therapy, battery of tests, no idea, boob. Who said boob? Difficult testing, what? Dollars, ugh, unsure, school setting, long test battery, and excited to learn more. Holy cow, what a range there. Am I right? All right, do you know who does auditory processing work near you? Do you know who to refer to? You see that patient in the clinic, they got red flags. Do you know where to send them? Okay. So 28% say yes, and 45% say no. If nothing else, I'm going to get that for you in today's session. Okay. Help me figure out what I want to talk to you about. I know you'd think that I would know really clearly, but even looking at the demographics, I think it might be slightly different. You may not have known that the green one was on the cards. Actually a client from the House-Ear Institute, one of the first 100 ABI clients. Oh, wow, look at that even spread. Okay, so only 27% want to see that short film. Interesting. Okay, fantastic. This is really helpful for me. Thank you, thank you, thank you. Last one. Give me one word with how you're feeling about how you're feeling right now as this talk is about to begin. You've been listening for a really long time today. How are you feeling? Usually I'm looking at people's faces a lot. And because I don't have the ability to look at your face because you're sitting there in your pajamas, I want to know how you're feeling based on what your thoughts of APD's work was before. This could be interesting. Boob, can I get a witness? Okay, let's see. People are feeling low. Okay, energized, inadequate. No, word, dandy, tired, excited, and interested. Okay, maybe this is not going to be terrible. Okay, fantastic. Thank you so much. That is really helpful. Oh, by the way, 1, 2, 3, you got 3rd place on the questions. Me, number 2. And number 1 is, who is it winning the big prize? Lauren. Lauren, you legend. I am so proud of you. Good job. Okay, fantastic. I hope you enjoyed that. That is a really nice place for me to start. Now I'm going to share my presentation and just make sure that the sound can come through. Stand by. Okay. Guess what? Guess what? I can share my computer sound. This is the best ever. Wonderful, my friends, because we've got some videos in here. We've got tasty deliciousness. Okay, kia ora koutou katoa. My name is Angela Alexander. I'm originally from Kansas, but I currently live in New Zealand. So once again, in the chat box, because y'all can say stuff in the chat now, say, if I ask you, can you spot an adult with APD? Say yes, maybe, or no in the chat right now, please, if you don't mind. See, you can put it in any language as long as I know that language. Fantastic. Good. Wonderful. Okay, cool. By the way, I may accidentally say client sometimes. In Australia and New Zealand, we say client, and in the US, patient. So I just wanted to be upfront there. So from Kansas, then lived in LA, then Virgin Islands, then Kansas again, then New Zealand, then Australia, and back to New Zealand again. So yeah, if you haven't seen my TEDx talk, you may not know that I'm a survivor of childhood abuse and neglect. My parents locked me in a basement for a wee while, and now I've come out of that thanks to brilliant foster care and wonderful therapy. I feel like I'm recovered from that. I have this beautiful daughter. Her name is Isabel, and holy cow, isn't it fun to watch auditory processing and auditory skills develop from a parent perspective. This is my husband and me back when we were hot. This is my me doing weird talks. I play roller derby. I do 1980s dancing. I sometimes enjoy my tricycle. Jack Katz is one of my best friends still. I'm going to say still. I like to make films, and I run an APD map and online courses for auditory processing. So I teach audiologists and speech language pathologists how to do the work I'm doing that I'm going to show you today. So first of all, a lot of people have let me know in the chat box and through that Kahoot that you are new to auditory processing. So let's first start by taking auditory processing and putting it on the continuum that you know well, and that is hearing. First, Erber's model of auditory skill development wasn't necessarily made with APD in mind, but it's a great way for us to integrate what you know with what I want to teach you today. So here is some framework. Awareness is your awareness to sound. It's your hearing sensitivity. If you aren't aware of sound, then we can often do cochlear implants, auditory brainstem implants, and hearing aids in order to assist with awareness. After we get past awareness, we get discrimination. Can you hear the sounds D and B? Can you hear the difference between those two sounds? If you can't discriminate those two sounds, that's a higher level of skill compared to awareness. The level above discrimination is identification. Can you hear D and B? And can you hear that those are two different sounds, and that the D is D and the B is B? And you need all three of these to get to the final level, which is comprehension. And as you could guess, comprehension has another stairway that leads up from there. Here is the issue that I think that we have in the hearing care profession. We think that as soon as we get a person above awareness, bam, they get straight up to comprehension. A person has a hearing loss, we put hearing aids on them, and if they have any problems with comprehension, we should go to 2 kilohertz and check and run real ear and make sure that they're actually getting the sound. But we're not doing this hard work right here in the middle to identify how somebody discriminates sounds and identifies sounds. And we've completely left the brain out of it. So here are my questions for you. What if the future of hearing care is bright and full of hope? What if we had more treatment options for people with and without hearing loss? What if it didn't take 3 hours to assess auditory processing abilities? And what if this is actually the best time ever to be an audiologist? Because for me, it is. We treat humans, not ears, all right? And clients often view audiologists as a widget provider. They only see clinicians as a person who sells hearing aids. But you know what? I'm not going to lie to you. I think even audiologists think that all that audiologists do are hearing aids. I think we're really operating in a small part of our scope. Do you agree? What do you think? I'm about to run with an analogy to auditory processing disorder to help you get more clarity on what auditory processing disorder is. I need you to really focus for this next 5 minutes, because if not, none of this talk will make any sense. We are detectives. We diagnose and treat complex problems. We look for evidence. The first thing we do as hearing care detectives is we're looking for evidence of problems, and then we're creating solutions to those problems. Now, here we go. Dig in deep. Think of one jelly bean as a single piece of evidence of auditory processing disorder. All right? One piece of evidence, one jelly bean. Where do we find evidence of auditory processing issues? We find them in symptoms and we find them in test results. So maybe a symptom is, oh, I can't hear in background noise, or a test result is poor speech and noise abilities on one of our tests. Some people have a lot of evidence of auditory processing issues, and some people have less. When a client comes to us, they think all of this evidence is going to confuse us. How many people have gone to the doctor and you are talking to the doctor and you're listing out all your symptoms and you're thinking, I'm probably confusing them? I think we've all done that, right? But if a client tells us, oh, I have dizzy spells, but it's only when I roll over to this one side and it only lasts for a short period of time, and they might think that all those things are kind of out of nowhere, but we can collect that evidence and tell them what problem we think they might have even before doing any kind of testing, right? They think we see this, a confusing array of symptoms, when actually we see this. Auditory processing specialized audiologists actually know how to categorize the difficulties, just like sorting the evidence, like sorting these jelly beans. So if we take symptoms and test results, we can figure out problems. And I also agree that the popcorn flavored jelly bean is potentially the best one. Just throwing that out there for Chuck. Okay. So when we know symptoms and test results, we figure out problems. When we know problems, we figure out solutions. Okay? When we know the solutions to problems, that's when we have clarity. And we cannot give clarity to clients unless we have that clarity ourselves. I am going to talk about one school of thought for auditory processing disorder, but there are actually 3 prominent schools of thought in auditory processing work. Feel free to throw in the chat box which school of thought you learned from or which ones you're using in your clinic. It is also okay to be agnostic and kind of do all of them. In November, next month, I'm giving a talk at ASHA, and it is a talk unlike I've ever done before. The 3 different schools of thought of auditory processing disorder are coming together, where the mentees of each school of thought will be doing a presentation together on the testing and the treatment. When we got together to discuss how we would do this talk, we decided to assess the same patient. So there's one 57-year-old woman who has a normal audiogram and has had 3 head injuries, who has decided to be our patient. We have already gone through the testing process for that, and I cannot wait to see what that talk looks like. And I hope that all of you can attend, because it's only $100 for a virtual pass, and it's going to be live streamed. What I'm about to show you is a slide I've never shown anyone because I literally wrote it today. The 3 different schools of thought have different priorities. They have different priorities of what we think that a patient needs when they are getting an APD assessment. I have not talked about this yet with my co-presenters, but just based on what we have had the discussions with this patient, this is what I'm sensing. And feel free to pop something in the chat if there's another priority you sense too. So here are the 3 main schools of thought. There's a neurophysiological approach. There's the Bellis Ferry, and there's the buffalo model. Neurophysiological cares a lot about specificity. We want to make sure, they want to make sure in the neurophysiological approach that it is definitely only auditory processing disorder, or that this is a really, they're really specific about it, you know, that they correctly reject things that are not auditory processing disorder. They care about site of lesion, even though we're not talking about tumors or pathologies like that. They want to know where this breakdown is happening. They often are looking for more technical solutions. They care a lot about multidisciplinary teams and referrals to outside clinicians for that work. What I am sensing from the Bellis Ferry is they also care about specificity, determining the pattern of test results to create a working hypothesis of the lesion. They care a lot about talking about compensatory strategies, and they prescribe auditory training apps to target specific auditory training skills. Now, what I'm about to talk to you about is Buffalo model. Buffalo model, in my opinion, is trying to relate auditory processing difficulties in day-to-day life to test results. One-on-one therapy between an audiologist or speech language pathologist is our primary way of delivering therapy. I think it's really in my lens, identifying the severity of each auditory skill is quite important. And I think it's really important. We are trying to give the client hope that these issues are treatable instead of focusing on compensation. I hope that helps. Can you tell me in the chat box if you found this as a helpful slide? Because you're the first people I'm trying it out on. Okay, so let's create clarity. And my goal is to show you how I create clarity and how I sort the jelly beans to identify what problems a person is having with auditory processing to see what we could treat. All right, this is Jack. Jack did pass away in July of this year. Absolutely gutting. I met him in April of 2004. And over the past 5 years, we've been meeting for an hour a week for him to tell me stories, because I was worried that I didn't have the rest of my life with him. And so I wanted to archive as many of his thoughts as possible. So very excited to have that. A lot of people think that this is his best work. Now, a lot of people say that you can carbon date an audiologist based on the color they learned from. Pop in the chat box which color book you learned from. Okay, we've got, ooh, another green. Chuck, you're in my cohort. Fantastic. We got some brown, red, green, red. I wrote in this one, the purple one, but absolutely legendary book. And I think a lot of people think that this is the special sauce. Jack was in clinic and wished that he had it. So he started this book, and we are working on the 8th edition right now. I've just submitted my chapter. Okay, so this is Jack. And this is why it's called the Buffalo model, because he made it at the University of Buffalo, not because hot wings are delicious, even though they are. I'm going to say that. So let me talk to you about the jelly beans, and we're going to actually do some activities together to start sorting the jelly beans too. All right. Here are just some of the symptoms and test results we see with each type of jelly bean. So I want you to mentally categorize. We're going to look at 4 different categories of APD problems, symptoms, and test findings, and then we're going to start sorting. So first, decoding is the ability to quickly and accurately digest speech, beginning at the speech sound level. So if a person has a hard time recognizing speech sounds, they may have difficulties with spelling. That makes sense, right? Their speech can also be indistinct and unclear, and they can even have poor speech recognition in quiet. So those are the blue jelly beans. The green jelly bean. So decoding is almost how quickly you get there. And then tolerance fading memory is having short-term memory difficulties paired with speech and noise difficulties. Those two aren't the same things, but they both, the function seems to co-occur in the same area of the brain. When we see a problem with one, we often see a problem with the other. So these people are often distracted by noise, have troubles understanding speech and noise. Sometimes these can also have some overlaps with ADHD because we've got this prefrontal cortex kind of situation happening, and they're afraid that they may not remember what they were about to say, so they might interrupt what people are saying. And these are the test findings that we'll see. Poor speech and noise abilities. The next one is organization. Maybe Chuck, maybe this is our popcorn flavored jelly bean. I don't know. Organization is difficulties with keeping things in sequence. And something that was really interesting that was observed in when they were doing an analysis of variance and analysis of covariance was that these children were often messy, that they had messy rooms and things like that, or wore their jackets at awkwardly. I don't know. Anyway. And the last one is integration, how a person is able to bring information across processing centers in order to understand a message. Okay, so let's say that speech sounds are like leaves on trees. If we passed 3 trees, if Alan and I are walking along and we passed 3 trees, and he knew that pine needles made a pine tree, and palm leaves made a palm tree, and oak leaves made an oak tree, and I said, hey, what were the last 3 trees we passed? And if he couldn't identify what those leaf shapes were, he might say, oh, I don't remember. But it wasn't that he doesn't remember, it's that he didn't know to begin with, right? So that would be considered a decoding problem, not being able to recognize something. The next one is tolerance fading memory, and that's difficulties remembering what you've heard or etc. So I might say, Alan, what were the last 3 trees we passed? And he might just say an oak tree because he only remembers the last one. And by the way, Alan, I'm not trying to point you out. I hope you're okay with that. Let's say that he has a problem with organization, and sound is like the trees that we've just passed. And maybe he says, oh, there was an oak and then a palm tree and then a pine tree. And integration, lots of people who have difficulties with integration might be like, what, we passed trees? Everything seems kind of overwhelming to them. So this is just a really basic analogy. Now, let's play a game. So actually, before we play a game, I'm going to show you what we like to call a vomit slide. A vomit slide is a whole lot of information that we should not ever expect anyone to be able to digest on a slide. But I just want to show you that these are the results of an analysis of variance and analysis of covariance of 200 clients. So these are all of the symptoms of decoding, all of the symptoms that we look, symptoms and test findings of TFM, all of the symptoms of organization, and all of the symptoms that we look for integration. Okay, so that's our vomit slide. If you want to take a picture of it, I'll give you 2 seconds to do that. Fantastic. And we're going to move on. Let's play a game. I'm going to talk like a client, and I want you to figure out which category I'm talking about. Okay. So in the chat box, as quickly as possible, I want you to type which color it is, okay? So I'm going to say one of the symptoms and you type it. Okay, troubles sequencing verbal items. Sarah's jumping right into it. She went straight to the 3. You know what? Y'all are super smart. We're just going to go. I want you to type the 3 little letters instead of the color. Okay, cool. All right, let's try this one. Which category would we look for difficulty spelling? Yes, good one. How about, good job. If you said DEC, you're correct. How about difficulties integrating audio and visual information? INT, good job. That's right. That's an integration one. Okay. How about distracted by noise? TFM, nice, wonderful. Okay, how about trouble keeping things in order? Trouble keeping things in organized. Whoops. All right, fantastic. Now I'm going to speak like a client. Okay, here we go. Let's try this. My audiogram is normal, but if I'm in even a little bit of background noise, I can't hear anything anyone is saying. Yes, TFM. Brilliant. Well done. Okay. Okay. Ignore the 1, 2, 3, or 4. We went way past that real quick. All right, now listen to this client. She is Australian, so it may be a little bit difficult to understand. Realize that what she is talking about is what is happening in quiet. And once you figure out what she's talking about, I want you to put that category in the chat.
When I was in grade 2, and we had a substitute teacher, and she was reading out the spelling words, and we all had to write the spelling words, and I just thought, they're right next to me. If I just have a peek and then I actually know what word she's trying to ask me to spell, I got busted.
And
yeah,
you weren't actually trying to copy their spelling. You were trying to figure out what word she had said.
Yeah, I'm trying to figure out which one it was, because when they do sound words, it's all the same middle sound. Like, it's all rhyming words. And I had to try and figure out which rhyming word I'll have to try and spell right now. Yeah, and then she pulled me up in front of the class and told everybody I was a cheater and I have no value in education.
Okay, this beautiful person is talking about decoding problems. She is not recognizing what the teacher has said.
When I was in grade.
And she feels like her first bullies were teachers, and she has now become a teacher herself because she had one of the most severe auditory processing issues I've ever seen. Okay, so an easier way to find out a person's jelly beans from their case history is to use questionnaires. So once again, like I told you, when a person is looking at all their, telling you all their jelly beans, it feels really confusing. It feels like this, right? So instead, we need to make things more clear by categorizing it. So we dump them into these 4 different buckets. Look, I mean, these they look like the popcorn ones, right? Anyway, so we dump all of these jelly beans into the buckets, and when we sort them out, we create clarity, right? That looks and feels a lot better. So there's this Buffalo model questionnaire. This is another questionnaire that Jack created. What he did is he took 100 clients who had been assessed with auditory processing disorder, and he asked their families, do you have any children who you do not expect have any auditory processing issues? And there were 30 children in families with no auditory processing issues. And he asked the parents to fill out a questionnaire on both of them. And what he found is that if a person answered yes 8 or more times on this questionnaire, they were also more likely to have test results that were consistent with auditory processing disorder. So 8, if a person has 8 or more yeses on these parts, this shows you their blue jelly beans, their green ones, their red ones, their yellow ones. These are APD in general. And then these ones were more kind of, they were questions that Jack was asking from a research perspective more than actually something being consistent with auditory processing disorder. Then we add all of these up, and of all the color-coded ones, if they say 8 on this, they are likely to also show auditory processing test results. Okay, how many items on the BMQ is considered significant? Put it in the chat box, please. The ocho, fantastic. Okay, good job, y'all. Okay, so here are all of the symptoms of APD from the Buffalo model. Now let's talk about some test result jelly beans. So the central test battery, which was created by Jack Katz, has 3 tests. It takes about 45 minutes to an hour to administer. We have the speech and quiet and speech and noise test. We have the SSW test, and we have the phonemic synthesis test. So if anybody remembers what those are, that's what this test looks like. I would say a majority of the time a person tells me they have problems with auditory processing abilities, we will see that come up on one of these test results. The SSW can also be adjusted for hearing loss. All right, so quantitative and qualitative. A majority of the time, audiologists look to see if something is correct or incorrect. Present, absent, response, no response, right? We're quite black and white kind of folks. And I think a lot of people feel uncomfortable with APD because sometimes it gets into a wee bit of gray area. Am I right? So let me show you something interesting. So in 45 minutes, we can get these kind of test results when we just look at correct and incorrect, the quantitative part. Now, here is the biggest piece of information that almost all audiologists are missing in our work currently. When a person, how many times have you been doing a recorded speech test and you have to pause the material for a person to respond? Have you had that happen? I know I did. And you know that a person's going to take a little bit longer to respond. Check this out. So these are test results from an auditory processing, actually an audiologist with an auditory processing disorder. So this is from before therapy and this is from after therapy. If I mark, this is when the stimulus ended for both of these, and this is when she responded. And you'll see before therapy, she took up to 2 seconds to respond. So a 2-second delay from the end of the stimulus to the beginning of the response. And then on retest, and even a little delay in between, on retest, she only had like a 0.2 0.2 second response time. We judge people based on their communication style. Now, how do we judge a person that takes long pauses before they respond? We might think that they're not intelligent. We may not think that they're paying attention when they're actually using a lot more effort than we would expect them to for simple stimuli. Here's the wild thing. Both of these results in a typical audiology clinic would get correct with no mark of a delay, no mark showing that it took far more time and effort than what most clients would have. What does this look like? Let me show you this patient. This video blows my mind. This is test 1. This is this audiologist. This is the first time I'm assessing her. This is test 2. This is right after she's had auditory processing therapy. And this is test 3, a year after therapy. She is 2 years older nearly in this last one than she was at the beginning. Watch how long it takes for her to respond.
Are you ready? Fruit, juice, cake.
Fruit juice cupcake. Fruit juice cupcake.
Isn't that wild? Hold on, we got to watch that again. So before therapy, she was taking almost 3 seconds to respond. And 2 years later, she's responding that much faster. Hold on, let's watch again.
Are you ready? Fruit, juice, cake.
Fruit juice cupcake. Fruit juice cupcake.
Tell me, yeah, they're triplets. Hilarious. Okay, all right, let's.
Are you ready?
So what is normal? To respond to something like in a quarter of a second is normal. She was taking sometimes up to 5 seconds to respond to an item. Now, normally for me to measure this, it is a painstaking process. I'm literally going from the end of the stimulus to the beginning of the response. But last week, I took 2 de-identified audio recordings of a test, put it into AI, and I found that a current patient was going from about 1.5 seconds, these are milliseconds, from 2,000 milliseconds to 290 to respond pre and post therapy. I'm really excited about this use case for AI because I think that delays are a critical piece of the critical piece of the puzzle. I know I'm just stealing one from the last talk. It's the piece of the puzzle that we're missing, if I'm honest. What do you think? Does that blow your mind? So the way that Jack Katz suggests is that anytime we sense that a person is pausing before they respond, we put an X with a circle in front of that item. We only count pauses before correct responses. If the result is incorrect, we've got enough information. But if we take quantitative data like that, and we also add qualitative data, look how many jelly beans we can get in 45 minutes. That's a disgusting amount of jelly beans, if I'm honest. All right, so once again, we've got these 4 categories of the Buffalo model. And how many problems or categories can one person have? In the Buffalo model, most often our clients have at least 2 categories. Sometimes they can have all 4, which is awful for them. If they only have 1 flavor, it's likely they can compensate to make up for it unless it's really severe. And decoding is the one we see most often, potentially from a referral bias, because these people are often children who are having a hard time understanding what they hear in school. They're having a hard time with spelling and stuff like that. Now, most of my case studies are adults. Can you pop into the chat box whether you mostly work with kids or adults? Quickly. Kids who have APD often become adults with APD, especially if they have hearing loss and unless we do something to help them. Okay, so I'm seeing a fairly even distribution in the chat, so I am going to keep my kid stuff in there too. All right, so here's a kid that was not able to get therapy pre and post. I mean, this is a year later. He still has auditory processing disorder pretty significantly. All right, once again, what's the youngest child you can reliably and behaviorally assess for auditory processing difficulties? Well, let me have Donna Geffner talk to you about it. Her test, the auditory skills assessment that can assess children aged 3.5 to 7, is amazing. You should totally own it. So at what point in your reports, at what age of the child will you actually write, I am diagnosing this child with APD?
Because the test goes down to 3.5, and it was at that point that we were able to get enough reliable data that we had an R score coefficient that was sufficient. And then we knew we had a 60% reliability there, which was very, very plausible for Pearson to accept it. And by the way, this test took over 4 years to 5 years to produce. It cost the company several $1 million to be able to really norm it. So when a child is 3.5, and that's at that point where we knew we could get a good hit rate on those kids. So I would be comfortable saying the child's at risk, because you got to give a little wiggle room here that there could be something developmental. But when I get a kid at 4.5 and 5 who fails that test, I will say he has an auditory processing disorder, because one of the things that we got in that test was the data of what children, normal children, do. And if this child is not meeting the criterion reference for normal kids, not only is he at risk, but he's very likely to have an auditory processing disorder. And if we say the word disorder, a school district, a pediatrician, a psychologist will sit up and listen. If you say the kid's at risk, there's more of a chance that that school district will dismiss him and say he's too young. Bring him back when he's 8 or 7 or he's 2nd grade. Well, we don't do that with language. We don't do that with articulation in our kids. So why should we do it with their auditory skills? We know early on if these kids are making it or not making it.
All right, fantastic. I hope that was so helpful. Now let me tell you about a 6-year-old. There was a 6-year-old that contacted an APD clinic in a university and said that they would like an assessment, and they said they didn't test children until they were 8 years old. The child finally returned at 8 for an assessment and found out that she had a moderate hearing loss. So what do we do from preventing that from happening again? We have to be more client-centered. We have to do a hearing test for anyone with concerns and refer families to clinics that are equipped to do this specialized work. If you can't do it, doesn't mean it can't be done. Wow, that was blunt. Sorry about that. But we want all children to read by 7. And if we know that auditory skills underpin early literacy, why would we wait to test auditory skills until after 7? Now, here is my daughter. You may be hearing her in the background as well. But this is her at a much younger stage. She's 1 year and 10 months. Hey, how about this one? Q. Q, that's right. What about? E. How about this one? A. B. 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 How about this one? That's right. Snake. That's right. Snakes start with S. What about Smeagol. Smeagol starts with S too. That's right. I mean, she's a Kiwi, so cool that she knows Smeagol. What you're seeing here is this is a probe, not therapy. I'll show you some therapy in a little bit. Kathy has just asked a really good question about what about children with multiple disabilities? Honestly, I think that we should be assessing and treating the auditory processing in everyone. Auditory processing and auditory skills is something that can change no matter what a person has going on, and we should be doing this work more often. So having multiple disabilities is actually probably a reason to assess auditory processing, not an exclusion factor. Okay, so hearing in the elderly, there was this crazy quote that Brent Edwards put out there. 1 in 5 adults who reported they have a hearing loss have normal audiograms. How many of us have had friends who are like, oh my goodness, I can't hear at all. And then you pop them in the test booth and their hearing test is normal. Wild. So I thought that was a really interesting idea. I mean, especially because there are lots of people with hearing loss who think they have normal hearing. This is a very interesting thought. Now, here is Jackie. Jackie is one of these people. She said, I have hearing loss. I know I do. So she went and had a hearing test done. And in October of 2013, they said, no, your hearing is normal. They said you may have an auditory processing issue, but no referrals or recommendations were made. In 2019, she went to her audiologist and said, I can't hear. They said, we're going to send you to an ENT. The ENT asked for the audiogram beforehand. And she did a quick SIN on this person and said they're within normal limits, no further action needed. And the ENT said no. Actually, the otologist said no and sent her to me. And let's talk about her case study. So she has problems following conversation and background noise, works in HR, and it's important to hear. She requires subtitles and reports learning difficulties as a child. If we look at her symptoms of APD, if we take away the ones she didn't report, you can see she has a whole lot of jelly beans. So if we add those up, remember how many she needed to get to on the questionnaire? 8? Does the questionnaire identify she probably has some difficulties? Heck yeah, it does. She's at 20. But how much does this impact her well-being? If you didn't see the TEDx talk, Jackie is the client I talk about on there, but we have even more clients now that we can show as examples. If you've never used the HHIA, it is so wonderful. And I'm going to give it to you today to start using in your clinic for your adult clients. And also, based on how much interest I'm seeing about kids here, I may also send you the Buffalo Model Questionnaire if you would like it. So stand by for that one. The HHIA is a questionnaire that you can use as an outcome measure. You can use it before and after therapy or before and after hearing aids, before and after any intervention to see if you're helping a person with their hearing problems from a psychological, an emotional, and social well-being aspect. So if a person says yes, an answer is 4 points, sometimes 2 points, and no is 0 points. So a sample question is, does a hearing problem cause you to feel embarrassed when meeting new people? If they say yes, that's bad, right? 4 points. So high scores are bad, low scores are good. All right, I love asking these questions out loud. Only takes about 2.5 minutes. Clients feel validated. I think recording it is wonderful if you get permission because it's a great pre and post for them. And it's a good way to guide your decision making. And I'm going to take you through that process of how you do that today. So good science is good observation. So as you watch the next video, I would like you to write one observation in the chat box. And I want you to remember that this woman has a normal audiogram. Here we go. Does a hearing problem cause you to feel embarrassed when you meet new people?
Yes.
Does a hearing problem cause you to feel frustrated when talking to members of your family?
Yes.
Do you have difficulty hearing or understanding coworkers, clients, customers, or wait staff?
Yes. Definitely.
Does a hearing problem cause you difficulty when visiting friends, relatives, or neighbors?
Yes.
Okay, put your observation in the chat. What are you noticing from her? Are you noticing that she is hunched over? She's struggling to understand. Yep, closing her eyes, leaning in. She's squinting. Absolutely. No eye contact. Good. Okay, so her score on the 26th of June, 2019 was 82 out of a possible 100 points. Just based on what you've just seen with Jackie, I'm going to go ahead and plot twist. She has auditory processing disorder. In a word or two, please write how it would feel to be a person with APD. How would this feel? Frustrated, isolating. Yes, frustrating, frustrating. Absolutely. Exhausting, overwhelm. Yes, and feeling stupid. That's the worst. I hate feeling stupid. And scary. Absolutely. These people are like, do I have like brain cancer? They like go kind of the worst thing. Now, let me take a second. So we did the central test battery with her. I actually think we might skip ahead because there's some, no, let's watch this part. That's fine. Here we go. So she's hearing speech in noise testing.
Sharp. 10. Eight. Can. Boil. This. Lube. That was really hard.
Did that actually make you feel like you normally feel in a noisy situation?
It made me feel stressed, emotional, and frustrated. But the emotive response, that emotional response was exactly the same as what it's like for me in a social situation where I'm just guessing at words because I have no idea.
Okay.
Shove. 10. 8. Camp. Oil. This. Do.
So it was a really cool situation to see how much. Could you guys hear a difference in how she responded? Her confidence, the strain, how quickly she responded. The next thing is the SSW test. You might remember this one from grad school. Let me go ahead and play this.
Are you ready? Fruit, juice, cake.
Fruit juice cupcake.
Fruit juice, fruit cake.
Are you ready? Night, light, stick.
Nightlight yardstick.
Night light yard stick.
Are you ready? Bird, cage, nest.
Birdcage crow's nest.
Bird cage crow's nest.
Are you ready?
Bookshelf drugstore.
Bookshelf dog spa. What did you think of that one? That was quite tricky.
You did it. Well done.
Oh, that was fun, that one.
Was that fun?
Yeah.
You actually enjoyed it?
Yeah, weirdly. Take these
Yeah,
out.
let's check them out.
I kept waiting to become exhausted. Woo! I know, I was like,
High five to you.
okay, I am really concentrating, but this is quite fun.
Yep.
I feel like I'm doing really well.
That's so cool.
Yeah.
Come on
And
out.
it's like, I really want to know how I did in the first test, because it's like, I'm sure it wasn't, because it wasn't easy,
Yeah.
but I feel as though the first time I did it, I was like, oh my god, this is so hard.
You're right. You're right.
And but
Last
that
time you did say, oh my god, this is so hard.
And I feel with that one, it was just like, okay, this is really cool.
Yeah. How good is that, right? So if we went to the quantitative and qualitative jelly beans, her initial test results were these were her initial test results. So these are all the potential test signs. These are the test signs we saw. I throw it into the jelly bean counter, and she had 14 pre-test pieces of evidence of APD. So if I put that, we need to see one test that's 3 standard deviations from the mean, or 2 tests that are 2 standard deviations from the mean to meet the ASHA or AAA criteria. So if you see 1 red or 2 oranges on her test results, as far as severity is concerned, she meets the criteria. So 1 red, I mean, holy cow, it looks like Christmas. There's so much ketchup on here. She definitely has it. I'm diagnosing her with ketchup. That's weird. But I want you to pay attention to the fact that 1 standard deviation still means that 86% of the population can still outperform her on this test. So that might not feel that normal. Okay, so in a word or two, please write how it would feel for a person with APD in the chat box from a clinician that they don't have a problem. Like before she has her therapy, how does it feel? Invalidated, absolutely, lost, dismissed, terrible. Am I crazy? Discouraged, relief, sad. Yes, all of those things. I completely agree. Jackie had 12 one-hour-long sessions of auditory training once per week for 3 months. Yes, all of these words are so right. So these are her initial test results. Here are her retest results. Now, this does not always happen with auditory training. It doesn't always go from red to green. And remember, like I said, 85% of the population could still be outperforming her. So for me, what's most important when I'm reassessing an auditory processing client post-therapy, I need to collect evidence of potential change from previous testing. So here were her initial therapy symptoms of APD. Here are her retest symptoms of APD. Here are her pre-therapy test results, post-therapy test results. So Jackie started with a lot of evidence and she ended with less. So we went from 20 and 14 to 6 and 3. So we want to reduce the jelly beans in that jar. Does that make sense? Please tell me in the chat. Most importantly is, how have the improvements generalized to her day-to-day life? What changes has this made for her from a psychosocial perspective? Let's check her HHIA. Also, watch for observations. Observe how she's responding. Does a hearing problem cause you difficulty when listening to TV or radio?
No.
Does it cause you to go shopping less often than you would like?
No.
No, it's not getting in the way of that.
No.
Does a problem or difficulty with your hearing upset you at all?
No, not now.
Does a hearing problem cause you to talk to family members less often than you would like?
No.
Do you feel that any difficulty with your hearing limits or hampers your personal or social life?
No.
Okay, put a observation in the chat box. What does she look like now? What are you noticing? She does seem more comfortable in answering, more laid back, more relaxed. I still notice she's not doing a whole lot of eye contact, but looking more confident. Okay. So after therapy, her score was 24 out of a possible 100 points on the questionnaire. So let's track those HHIA questions over time. So 82 was the first time I met her. 84 was on her first test date. 30 was after therapy. 24 was at her retest. And then I called her and gave her a follow-up phone call in June, and her score was 14. So I was able to continue tracking this data. Then I got accepted to do a TEDx talk, and I asked her, could I tell you your story on the world stage? And then I was given one ticket, one person who could come along to be my special guest, and I asked her to be that person. And afterward, we had a debrief on Zoom and see if you notice any changes in her now.
I was really honored to be your guest. There was one part where you show the comparative results and the whole audience just went, oh, and I was like, I know. And because everybody around me, they get how amazing it is.
What was it like to watch your own video again?
I felt really sorry for that poor woman that was going through that first test. I remember how exhausted I was at the end of that testing. I was so tired of feeling worthless, you know? It was the first part of my journey of returning to who I was supposed to be. And then I watched the second video and I was like, oh, yeah, there I am. But that's not who I am now because I've moved forward again. The big thing for me is both of those people looked so much older than I do.
So now, have you done any more auditory training, like formalized auditory training, since you did the 12 weeks?
Nope. No, I haven't. The APD diagnosis and the therapy did a couple of things. The first thing was that it acknowledged that I wasn't making it up. And it affirmed to me that my intuition was correct, that what I had been experiencing was not normal.
We are a year and a half from when we did your retest. So how do you feel like your processing is going now?
I feel as though my ears work better than most normal people. I pick up a lot more detail now, and I'm pretty sure that normal people don't.
What would you say to a person who says auditory processing disorder doesn't exist or it can't be treated?
I have lived it. And I know that pre-treatment, I was not making up my symptoms. And I didn't just magically start paying more attention after I had therapy. I was still the same person, but I stopped being a person in pain.
Would you consider yourself still to have an auditory processing disorder?
That's a really good question. Would I? No.
How cool is that? Look at that smug look on my face.
I was
so yeah, this is my TEDx talk called Escaping the Hidden Prison of Auditory Processing Disorder. The first 3 minutes, I do a bit of trauma dumping. Sorry about that. So skip past the first 3 if you don't want that. People the comment section is really not ideal. Why didn't people tell me I had APD, etc. At that 2-year follow-up, I did the HHIA again, and her score is now 2. So I have this dashboard where I can track how a person responds. If they say yes, it's red, orange sometimes, and green, no. So you can see a person is really consistent with how they respond. Yes, yes, sometimes no, no, no. This one right here is, does a hearing problem cause you difficulty when listening to coworkers, clients, or customers? She has a coworker who is from Ireland and she has a hard time with his dialect. So that is her only sometimes. Okay, I'm going to teach you how to leverage the HHIA in your clinic. Okay? I'm going to teach you now how to spot an adult with APD so that if a Jackie comes to your clinic, you will not miss her. All right, here we go. Fantastic. All right, so, okay, Chuck is like, but you have to set the stage though. If people regress, what is that like? Or how does that present? If they have a head injury afterward, they might regress. In general, I do not see people regress after the auditory training with Buffalo model. I do have a randomized controlled trial starting in February. Hooray! Real science, my friends. Okay, so the current HHIA classifications are 0 to 16 is no handicap, 18 to 42 is mild to moderate, 44 to 100 is significant. Now, I looked and there is zero research for these categories. I think that they were trying to have broad enough categories that it would almost track with an audiogram, but actually the way in which it's different from an audiogram is its strength, not its weakness. Because I can tell you, a person who says yes to 11 questions versus a person who says yes to all 25 are very different levels of severity. So, word to the wise, really quickly. Title suggestion. Take the word handicap out from the title. HHIA is good enough. On question 8, change it from handicap by a hearing problem to disadvantaged by one. And I have an editable version that I can put in the chat box shortly for you to use in your clinic. So instead of having these 3 classifications, I would like anyone who works with adults here to go from these 3 to looking at it like a fire scale, like an audiogram. Put it in the same categories as the audiogram. Of course, profound can go above 100, but generally think about it with these same levels of severity. Jackie, at her initial testing, her audiogram was normal. Her HHIA was severe. That is a red flag. That is how you spot an adult with APD. After therapy, mild, we're getting there. Retest, still mild, stable. Now, her HHIA is as good as her audiogram. Winning! A med student also had something significant like this. His retest results after therapy did not show all green, but his HHIA improved significantly. Initially, his HHIA showed red flags, retest, normal, winning. But then also, if he wants extra therapy, we can do app-based therapy, more targeted things like that. So I think starting off with the Buffalo model auditory training, Jack's auditory training, is a great first place to start, and then you go from there. I have also been published recently with Bob DeSogra. There was an ER doctor who reported brain fog post-COVID-19, does not report any auditory processing issues before having COVID-19, and his retest results after therapy were within normal limits, and he reports a reduction in the feeling and the perception of brain fog from auditory training. Bob DeSogra has a hypothesis that the auditory pathways are also included in the anatomical descriptions of where brain fog is occurring, and maybe by improving auditory processing abilities, we can improve the function in those pathways. That's the theory. We will see. HHIA pre and post therapy on most clients. At the beginning of therapy, these are 12 clients that I saw in 2021. You'll see at the beginning of therapy, it is lower, post therapy, better. In the middle of therapy, sometimes it gets worse. I think these patients may not have realized how much auditory processing was affecting them before. This dark green line, this is a red flag for me. A client who goes through all the auditory training and their HHIA doesn't change, this is uncommon to see, but it also shows me, hey, there's red flags. We need to keep working. We need to figure out what's going on here. All right, let me talk to you about how to troubleshoot treatment for clients with auditory processing, red flags, and normal audiograms in your clinic. I think you should start with the easiest solution first. For me, that's an auditory processing evaluation. But for you, maybe not, based on what you said in the Kahoot. Or you can do treatment as a part of a diagnostic process. What kind of treatment? Auditory training. I'm going to talk about auditory training in just a little bit, but you may start with a hearing aid trial, potentially. So we can do a hearing aid trial to see if there's a technical solution to this problem. I have a bias that children, we should do therapy first and devices second. Now this is, this is in, if there's a clinician that can do this work. I mean, there's quite a lot of privilege in me saying this, but I think that it makes more sense. If it was my kid who was having a hard time with auditory processing, I would not want devices first and therapy second. I want her to be able to live without devices if that is possible, if she has a normal audiogram. Adults above 18, we have more flexibility. Now, the Roop et al. 2018 mild gain hearing aid article is wonderful. She doesn't necessarily use a diagnosis of APD. She uses the HHIA to identify people who may have difficulties with what they hear. They compared 20 adults with normal audiograms with no hearing complaints and 19 adults with self-reported hearing difficulties despite a normal audiogram. So 20 over here, normal audiogram, no problems, 20 with, or 19 who do report difficulties. With no hearing complaints, that group, their average score was 0.1 on the HHIA, and the ones with self-reported hearing complaints had an average score of 38.4. So on average, they said no to every item on this one. And on here, it was kind of that mild level of an HHIA. The higher the HHIA scores, the more hours the client was likely to wear the hearing aids on the trial, and the more likely they were to purchase them afterward. Vomit slide, my friends. Here are the settings for low gain devices. They set the hearing aids with 5 to 10 dB for soft and conversational inputs from 1 to 4K with no gain for loud inputs. Take a picture of this slide if you would like it. Fantastic. Okay, here is the process. Pre-fitting HHIA. I feel like I'm flying blind without an audiogram and an HHIA, if I'm honest with you. But go ahead and set them up. At the follow-up, even a week later, do another HHIA. Has it dropped? Awesome. On the right track? No. Consider trialing with an increased tech level. At the follow-up again, do another follow-up afterward. Do another HHIA. Has it dropped? Good. Or no, consider trialing with an increased tech level or a remote mic. At the follow-up, do another HHIA. I mean, of course, if you're on the right track, you could be done with the patient by now. But if you're not, then consider referral to an auditory processing specialized audiologist. You may actually want to do that even before. So what if we had fit Jackie with low gain hearing aids and not offered auditory training? Would she still be wearing them? Would she still feel like she has APD? Would she need to worry about moisture, wax, and charging them every night? Would she have to have a remote mic? How much would she have paid for this technology? How often would she need to replace the hearing aids? And would this have been in her best interest? What if it's you and you have a normal audiogram and auditory processing complaints? Would you rather have auditory training or would you rather have hearing aids? Kind of a personal decision. All right, I saw a lot of you were in California. The last time I did a talk in Cali, there were not that many clinicians doing this work. There are a lot more now, which is awesome. If you are listed on the APD map, please put that in the chat box. This is where the APD map is located. This is the website with the map. You can find a clinician specialized near you by using this QR code. This is the LA area. Quite a lot of people. If you see and maybe you live in Oxnard and you're like, well, actually, I should be doing this work then. In San Fran, here are these, and this link takes you to the same page, by the way. So a lot more people there. And there are clinicians who are doing this work 100% over Zoom, like I do. I do all of my testing and all of my treatment over Zoom. So the jelly bean is neither made of jelly nor is it a bean. Discuss. All right, so you now know enough to be dangerous. I'm going to now take just a quick moment and I'm going to put the HHIA in the chat box. Now, if you would prefer to get a copy of the 20-minute version of the talk that I gave, you can join this, get this free course here. If you just want the HHIA, let me grab that for you now. I'll even put the Word document in so that you can add your, there we go. It's sent successfully. If you don't see that in the chat box, let me know. You can even add your logo to it. Craig Newman, who developed the questionnaire, said that anyone can use it for free as long as they keep his reference at the bottom. You can also connect with me here. Don't worry, my talk isn't done. Woohoo! All right, now that I have gone over how to assess for APD, we need to talk about how to solve the problem. And I was going to change things up to show you the film that we had created called Between Two Ears, but it actually got the least amount of responses on the questionnaire that we ran at the beginning. So this film is amazing, but instead let's spend time talking about case studies and how we treat things. If you would like to see this 20-minute film about a man named Matt Hay, who was implanted with an auditory brainstem implant by Gerald Brackman in 2004, he is having outrageously amazing just everything. His story is incredible. I'm going to tell you his case study, but this film that we made is really beautiful. And I hope that you come along to the instant premiere that we run on this. We're going to be doing it in 2 weeks' time. So if you jump onto this, I would be happy to add you to the premiere list. Whoa. Okay. I didn't tell you I was going to talk about auditory processing treatment, but I feel like I can't show you these kind of magical results without showing you how we get there. How do we get these outcomes? Well, when we treat auditory processing in a client, we are solving problems and reducing the impact. Oh, that link isn't working. Stink. Hold on just a moment. Let's do this one instead. All right. There you go. That is the website. All right. When we treat auditory processing in a client, we are solving problems and reducing the impact of APD. So we know that when we take the problems and we figure out the solutions and we figure out the jelly beans, we can identify, okay, the problem is this person doesn't recognize speech sounds. They aren't doing it quickly and accurately. Our solution is to teach them to recognize the speech sounds. If a person can't understand words and background noise, guess what? We can help them to learn how to understand words and background noise. If they can't sequence what they hear, we can help them with that. And integration, guess what? We can do that as well. Jack Katz, who is the Are You Ready guy, came up with a toolbox of solutions. Now, Chuck, you asked what Jack is up to nowadays, and he passed away in July. Gutting. But this man has made an amazing legacy that we can really enjoy for years to come. So these are the different ideas. These are the different activities we can do to reduce the jelly beans in a person's jar. The first round of therapy, the first 12 hours of therapy that we do for a person is pretty similar from one person to another. What changes is the things we need to do to keep that person engaged. Now, we only get one jar and we have to make the most of it. So if a person has ADHD gumballs, it can look like the jelly beans, but it doesn't mean that the jelly beans don't exist as well. So what we can do is we can do therapy to reduce the jelly beans in the jar, and the ADHD gumballs may still be there, but maybe they won't be as big of a deal because the person can understand what they hear. So I have no problem assessing a person who has autism or ADHD or dyslexia. In fact, quite a lot of our patients have problems because APD does not always occur in isolation. This is a child who has something called pachygyria. The gyri of his brain are broad and flat. His brain does not look like your brain, unless you also have pachygyria. What I want you to listen to here is something that what Jack Katz would call the otitis media dialect. He sounds like he has had a lot of ear infections. Listen to his speech. Does it sound indistinct and unclear?
Hi, how are
you?
Good.
Are you having a good day?
Good.
Awesome. What's your favorite thing in the whole wide world?
Racing game.
Really? Tell me about that.
I work for Auditory now.
Oh.
31 now, so. Yeah, so how are you doing?
That's cool. I'm doing very well. Okay, this is the face of a person who has no idea what's happening. Trust me, Chuck, these moments were way more awkward than you asking a very kind question. So see if you can hear a difference between his speech here and after therapy. And by the way, from this time to that time, he's receiving reduced speech therapy services because of COVID. Okay, see if you can hear a difference in his speech.
How are you doing?
I'm doing really well. How are you?
Good.
Good, fantastic. Okay, so can I ask you some questions? What is your favorite thing in the whole wide world? What do you love?
Play game.
You like playing games? What kind of games do you like playing?
Xbox One.
Oh, Xbox One. Is there a certain game on Xbox One that you like?
I play like cars.
Oh, is there a car racing game on
Racing
there?
one.
Yep. Hi. Fantastic. Okay, so we can train the brain to get the gain. Could you guys hear a difference in his speech? I hope you could. I'm going to skip this video, even though it's amazing. Okay, let's talk about auditory processing and hearing loss. So I used to think when I was first getting started in here, auditory processing is over here, hearing loss is over there. But the more I've been working on it, the more overlap I think there is. And I wonder if this moment, like right here in this space, are these the clients we've been taught to counsel about having realistic expectations? And I kind of wondering, is that BS? Are we just not doing enough work to help them get the goals that they want? They want these outcomes, and instead we're holding them back. I've never once heard Jack Katz tell someone that there's limitations of their auditory system. All right, so hearing loss peppermints can affect the flavor and presentation of the APD jelly beans, but it doesn't mean we should ignore them. So how do we know what clients with hearing loss might need processing help in addition to amplification? Guess what? You can use that HHIA. And sometimes there are clients who have a really severe HHIA with a moderately severe audiogram. Post-hearing aid trial, sometimes this gets better and we are winning. We love that. Some clients, after a hearing aid trial, it stays the same. And those are our red flags. When we don't give up on our clients, they don't give up on themselves. And then here are the clients. These are real weird, where the audiogram is moderate and their HHIA is normal. Yeah, these people don't want help, which is fine. You know, it's okay. I would say seeing patients with denial is very rare in the auditory processing space. All right, this is Matt Hay. By the way, he's an amazing keynote speaker. Alan, you should consider him for next year. Book him while you can afford him. So Matt Hay, there was a story about him on NPR about his hearing loss journey. It was so remarkable that Channing Tatum's publicist picked up on it and bought Matt's story to make a film about him for Paramount. And then I got to meet Matt, which was amazing. And I was like, hey, could we try to do some auditory processing work? Could we do auditory training that I'm used to doing for auditory processing disorder? And could that take your speech understanding even further? He had had his ABI for 16 years. He says for the first 2 years, he didn't have any kind of open set word recognition abilities. He trained himself how to understand what the information his ABI was giving him by listening to music that he knew before he had his ABI. He has neurofibromatosis type 2, by the way. So he listened to music and he trained himself to hear speech based on that music. It's an amazing story. I'm not doing it any credit. But his hint sentences in quiet were 64 and 67% correct when I met him. So this is 16 years after the amplification or after the implantation. I think sometimes when a person is doing better than what we expected, we might just pat ourselves on the back and go from there. Matt says I was the first person who he told his speech recognition scores, and I said, I think we can do better. The client doesn't plateau, the clinician does. So let's dig deeper. Here is his phoneme recognition test before therapy. Listen to see if you can hear some distortions in how he was recognizing speech sounds. And bonus question, which category would that be?
This is the phoneme recognition test. List A. V.
Ah.
This is the phoneme recognition test. List A. V.
Ah. Buh.
Oi.
Oi.
J.
Eh.
Okay, that's interesting, right? Okay. And by the way, if we can assess a person with an auditory brainstem implant, we can definitely assess you, Kathy. Okay, so the phoneme, those were his first results. Here is after some auditory training.
This is the phoneme recognition test. List A. Oi.
Oi.
J.
Bah.
Ah.
Ah.
This is the phoneme recognition test. List A.
Okay, so he was able to get a whole lot more afterward. Okay, so if a person doesn't recognize speech sounds and we teach the person to recognize speech sounds, what does that look like? So I'm going to show you a little bit of something called the phonemic training program. Here is Matt in session 2. Here's the next sound.
Okay.
Like not, next, nincompoop, N.
Yeah, all right. I don't know if it's an electrode or what, but this is a sound that does not sound to me naturally.
Cool.
It sounds to me like you're saying I, Y, and then maybe an N, but it's very like nasally, and it just does not sound like B, sounds like a B. This does not sound like the letter N at all.
Okay, so that was session 2. Let's look at and this is one of 4 activities we do in the first round of therapy, 1 to 4 or 5. Here's Jack Katz. He jumped in on a few sessions. So watch how it goes in session 4. Matt, you are doing amazingly well. And Jack, you're doing pretty well too. You keep up the good work.
Practice, practice, practice. Okay, here's a little bit of a challenge for you. So, N. Exactly right. Exactly right.
I was pretty excited about that. Okay, here's session 6.
Any one of them. Ah. B.
B.
Eh. D.
D.
N. That is amazing.
I'm a bit of a muppet. Okay, so after our therapy, his hint sentences in quiet went to 96 and 84% with his ABI. And his AZ bio sentences, they had not done previously because they said they thought it would be too hard, but he was able to get 77.6%. And so that was quite exciting. And we need to train the brain to get the gain. right? If 1 out of every 10 patients with an ABI has open set word recognition, what if we could be doing more of this for them? So once again, not rocket surgery. I'm going to go a little bit off script and I'm going to jump ahead a little bit. I was going to take you guys through some auditory training. Let's do, pardon me. Okay, so like I said, I do all of my work online. Sometimes with kids to get them to maintain attention, I'll be a Zoom avatar. This kiddo, if she was looking at my dumb face, I would get like maybe 1 or 2 minutes out of her. But if I was a bunny or a fox or a bear, she would be on therapy for an entire hour. Let's have a quick listen. She's had 10 sets of tubes. She has autism, ADHD, and she has Down syndrome. So here we go.
Hi, Z.
Hi, Steve.
How are you?
How are you?
Oh, it's so wonderful to see your face.
Bye.
I'm Bunny, and this is my friend Amber. Do you remember us?
Amber.
Amber, that's right.
La.
Okay, Z. Point to D. Good. You did it. Let's try it again. D. Yes. A dinosaur starts with D. How about D?
Good job.
The dog is digging. Good job, Z. D, D, D. Beautiful. Oh.
Good job.
Love heart. Where is E?
Good job.
Oh, you did it. You're the best. Where is?
Here is another decoding activity we usually do at the end of a session. So this is called phonemic synthesis.
Do you remember this game? We played a game with sounds last week. Do you remember this one? If I say k, ow.
Cow.
Yes, you did it. How about ooh?
Well done.
You did it. Eat.
Yes.
Yeah. Yuck.
Well done.
You did it.
Clean.
Shh. E.
See.
Well done.
Wow. Egg.
Well done.
Egg. You did it. You did great.
Okay, so so you can
You
see how
remember
she's
this
doing
game?
with those ones. Hold
We
on just a
played a
moment. There are clients who are not ready for amplification or cochlear implants. And I think what I'm going to say next, I'm actually going to finish up. I'm going to take the last 10 minutes to take you through a different case study. This is a really, really important case study. All right, strap in. This is the last one, my friends. I don't know how you're doing from an auditory fatigue standpoint, because we've gone through quite a lot. This case study was a life-changing moment for me, and it may be a life-changing moment for you as well. This is a case study named Lila. I call her Lila. It's not her real name. She's an audiologist who was unilaterally implanted. She had a sudden hearing loss at 16 during a snowstorm where she couldn't be seen for a week. Ignore the weird numbering. She's bimodal, wears a hearing aid on the left ear and a CI on the right ear. She was implanted February of 2021, activated in March of 2021. Listen to a recording of her first phoneme recognition test, me just checking to see how she's hearing each phoneme.
This is the phoneme recognition test. Shh.
Shh.
V.
Raspberry.
R.
O.
Oi.
I. It sounded like a click.
J.
U.
Okay, so
This is the
I thought this was really interesting. Now, because she's an audiologist, she knows a lot of word recognition lists, but she doesn't know the W22s that I use. Hooray! So that was quite handy. So her right cochlear implant side, we did a quick speech and noise test. For these ones, I was actually streaming direct to each device individually through telepractice. I just wanted to see at a comfortable level how she did with words in quiet. So before we did any therapy, her right ear that had just been switched on was at 44% correct already, which is really quite incredible. The left hearing aid ear before any auditory training was at 64% correct. If I'm honest with you and me, I actually wasn't doing this test because I didn't do the therapy because I thought any changes would happen for the left hearing aid ear. 5 weeks into the therapy, I needed to give a talk, so I decided to do a quick probe to see how we were doing. See if you can see some changes happening in her phoneme recognition abilities.
This is the phoneme recognition test. Shh.
Shh.
V. R. Oi.
Oi.
Okay, so you can see that her decoding abilities, her blue jelly beans are getting better. Some of those sounds weren't even sounds that we trained, which kind of blows me away.
This is
Okay, now let me show you the moment that blew my mind. Okay, so she had 44% correct in the right ear at the beginning of therapy. Left ear was at 64% correct. After just 5 sessions of auditory training, she got to 52% correct in the right ear for an 8% improvement in her cochlear implant ear. And I was like, this is awesome. I am stoked about that. And then the left ear got to 92%, from 64 to 92 halfway for a 28% improvement. And I was like, that's awesome. I did not see that coming. And then the next thing she said blew my mind.
So does that mean that if I would have gotten auditory therapy that I might not have needed a CI? The FDA protocol just says you have to wear hearing aids that are set appropriately for 3 months. I've been wearing hearing aids set appropriately for years and years. Nowhere in the FDA does it say anything about oral rehab. I love my CI. I feel like I understand things so much better since getting it. It's really frustrating that oral rehab wasn't really an option. Now I'm like seriously wondering, would hearing aids have been enough? And I can't go back. You can't like do over, the CI's already there, but now I'm wondering, like, that's always going to be in the back of my head. And it wasn't really an option. It really makes me wonder why oral rehab isn't a part of the protocol.
That was one of the most significant moments of my professional life. I walked in circles for hours that day because I couldn't quite take all of that in. Because I'm a good audiologist, like many others are in this room, you're probably wondering, what did her pre-implantation audiogram look like, right?
So does that...
This is her pre-implantation audiogram. She met that 60-60 rule. But, I mean, one of the things that I think is really important here is that nobody did anything wrong. We are operating with what we know right now. She was on her cochlear implant team. She's still glad she got her cochlear implant, but it raises questions that we need to answer. So we've also had some recent retest results. Her right ear is now at 72% correct in that ear. Left ear is still at 92, which is wonderful. I've also asked for independent measures from her cochlear implant center. Unfortunately, they don't test the left ear because it doesn't have a cochlear implant. I'm like, but the other half of her head still exists. So please go ahead and test that other side if you can. She is doing remarkably well with her cochlear implant. So what if we started auditory training before implantation instead of after activation? What if word recognition scores are more dynamic than we thought and didn't just get worse over time? What if we assessed auditory processing in people with severe hearing loss? And what if this is the real value add that audiologists can be in our evolving field? I believe we need to be training the brain. We need to train the brain to get the gain. A few final thoughts. I don't care what buckets you sort your jelly beans. Can collect all the evidence, solve the problems, have more than one solution, harness the power of the brain and its ability to change. And when you realize you don't have enough tools in your toolbox, be brave enough to expand it. Don't forget, 1 in 5 adults who reported they had a hearing loss had normal audiograms. To ask yourself the question, have I done enough? With adults, I use the HHIA. With kids, I use their test results. The purpose of an APD assessment should not be to tell a person if they do or don't have a problem, but to help them with the problem they tell us they have. Referring someone is doing something. Every client can have their auditory processing abilities assessed. Every client can have their auditory processing abilities improved. But are we ready to help them? Train the brain to get the gain. It is really hard sometimes for me, if I'm honest, to do talks like this where I am just a head talking to myself on the screen. I really want to thank everyone who put things in the chat box. If you can tell me a takeaway from this talk, put that in the chat. I would really love that. Someone asked for the QR code. Here is the editable HHIA. That's where you can connect with me as well. Really quickly, I'll come back to this slide. Here are some references. Please do reach out and give me feedback directly. I teach all of this. I teach how to assess, how to treat. This is not a sales presentation. I'm not the only person who does this kind of instruction, but I think that this is the future of audiology. Thank you for listening.
Thank you so much. I have a little list of questions here, if you have a minute or two.
I mean, I'd like to talk about it all day, but let's also let Virginia have time. Virginia, go ahead.
You don't want to answer any of these?
No, I would love to answer. Let's go.
Well, let's just take a couple of these. What about kids with multiple disabilities?
Yes, absolutely. Just get rid of those jelly beans. We want to have every child living as the best life they can possibly live. And one of the best ways to do that is to improve their auditory skills. This is something that can change. Children with multiple disabilities may have things that aren't as easy to change. Somebody had asked how you test somebody who is nonverbal. There are tests that are auditory processing tests, like the auditory skills assessment, that have parts within them that are picture pointing tasks. You can use that. Our goal is to gather as much data as possible to figure out what the problems are and treat as many problems as possible.
Very quickly, will you be sharing those slides?
I can share some slides. If a person, what's the best way? Yes, I can find a way to share a link with you, Alan, for the slides.
Okay.
And you can distribute it.
What day is your ASHA presentation?
I believe it's Friday morning, and it's going to be considered a centennial talk, so it will get quite a lot of promotion. We have 2 talks. The first talk is about how the 3 lenses look at auditory processing disorder from an evaluation side, and the second talk, that's an hour later, is how we treat auditory processing disorder.
Okay.
And we're using this case study to demonstrate those things, which will be super fun.
Just a couple more here. How would you test deaf, blind, autistic, or nonverbal child?
Yeah, so the ASA is a really great test. I think, sometimes we start with a working hypothesis. So I have assessed a child who is nonverbal. I was basically taking in every phoneme they could say, and then I went and observed and watched to see. I just kind of did some qualitative observations, and then we started with auditory training, which was amazing. So just being adaptable, right?
Final question here at the risk of being a pain in the butt.
Never. I love it.
I have single-sided deafness and wear a bicross hearing aid. Could the tests be used on me?
Absolutely. As long as the one patient I won't see are people who are no longer alive. But other than that, no, I think we can assess the auditory processing in anyone.
And while you've shown us this, how you assess a person online.
So we assess people online. There are a couple of things that are really important. If a person is getting dichotic stimuli, we actually have to log into a portal on their side and share their sound back with us. If not, Zoom has a lot of capabilities that we are really lucky to have. We can share computer audio toward another patient. So we can share audio from our computer to the other one. Harvey Dillon did some research that demonstrated that there can be as much as a 30 dB HL difference in presentation levels without seeing a demonstrable change in a person's auditory processing performance across several tests, which is amazing. So basically, we want to see, we can get out of the test booth. We want to see how a person is hearing when stimuli is delivered to them at a comfortable level.
Right. Let's see. Oh gosh, they just keep coming.
Sorry.
Let me just stop with this final one, and then they can always touch base with you on your website.
No problem.
How can I learn to do this type of training? Obviously.
Yeah. I teach this online. There are actually a few people who are in Auditory Processing Institute who are here on this call. Hi. And then also the International Guild of Auditory Processing Specialists. If you're a person who likes to learn in person more often, I'm not affiliated with IGAPS, but they do, igaps.org. They also run weekends. So you may want to look into that as well.
Okay.
Thank you so much for the opportunity. Thanks everyone for participating. I really, really appreciate it. And I would love to come back next time.
Fascinating talk. Thank you so much.
Thank you. You're welcome.